Ladies and gentlemen, please turn your attention to the stage as we begin our session. Ladies and gentlemen, please welcome your panel on How Drug Trafficking is Fueling the Opioid Crisis, moderated by Senior Vice President of Medical Strategy and Government Affairs at Heron Therapeutics, Anita Gupta.
Good afternoon. My name is Dr. Anita Gupta, and I'm pleased to be here today to moderate a conversation on how drug trafficking is fueling the opioid crisis in the United States. The third wave is the wave regarding fentanyl in the United States. And the CDC statistics on America's opioid crisis is powerful and sobering. On average, 130 Americans are dying every day from an opioid overdose. From 1999 to 2017, more than 700,000 people have died from a drug overdose. And in 2017, the number of overdose deaths involving opioids, including prescriptions and illicit, was 6 times higher than in 1999. The cost to society is also very large, upwards to $78.5 billion in 2013. And this includes productivity in workplace, healthcare costs, and criminal justice expenses. And the cost is only expected to rise in the coming years. A new projection model that was just published on opioid overdose deaths suggests that slowing the epidemic and its upward trajectory in 2025 will require broad-based action and multi-pronged intervention. Today, here at Milken Global, I'm very honored to have a very distinguished panel, but we're going to trace this third wave. What is it? How can we stop it? And where did it begin? This intertwined use of opioid pain medications, heroin, and now the synthetic fentanyl analogs. We'll focus on this. We'll focus on the new driving force of the epidemic. This new third wave, which started in 2016, has given a new propulsive force. And because fentanyl is 50 times more powerful than heroin, smaller trace amounts translate to bigger profits. We're going to talk about 2 structural elements here today: social determinants and economic determinants. To understand this, determine our nation's health, and understand how we can get out of this and lead our way to drive shared prosperity and health together. Again, I have very distinguished guests today. I'm very honored to have you all here today. I have Lynn Goldman, the Michael and Lori Milken Dean of the Milken Institute School of Public Health of George Washington University, Michael A. Davis, the Assistant Special Agent in Charge of the Drug Enforcement Administration of the Los Angeles Field Division, and Adrian Lowe, the CEO and Program Director of the International Spine and Pain Institute. Thank you all for being here with me today.
Thank you.
We're going to take a deep dive on this issue of drug trafficking and the third wave of the opioid crisis. The goal is really to drive for a healthier, prosperous United States, to raise awareness, to really understand the conversation on how to move the needle, how to get all our hands on deck. And so we're going to have 3 questions we're going to address. What is the role of drug trafficking and money laundering in fueling the third wave of the opioid crisis? 2, how can we strive for a healthier country today by combined efforts on federal, public policy, private partners to drive solutions forward? And what are the innovative solutions to this third wave of the opioid crisis as our nation's moving more to a technological society, a more informed society on the treatment of pain and other public health substance use disorders? Lynn, I turn to you first. You are a leader, and you are also a dean, a physician, a mentor to many students, an overall collaborator. Your reflection on this issue of public health is paramount, and your concerns around the social determinants of health is also very important. I'd like to hear from you, your initial thoughts on the CDC statistics and on this third wave of the opioid crisis.
Thank you so much, and thanks so much for the Milken Institute's willingness to to dive into this issue, which is so important for public health in our country today. I'd like to put up the first slide just to be able to show what the CDC is really talking about when they talk about these 3 waves. The first wave being the rise in prescription opioid overdose deaths. Of course, the deaths are the tip of the iceberg for the numbers of people who are actually addicted or at risk. The second wave, the rise in heroin overdose deaths. And the third one, the rise in synthetic opioid overdose deaths, which is the dark blue line, which you can see is nearly an exponential increase in deaths from these synthetic opioids. And if you can look at the second slide, what we're really talking about in this first wave are analgesics that were prescribed by physicians, but sometimes misprescribed. And so I would say arguably, in a sense, that drug trafficking and the making of profits, illegal profits from drugs was a part of this, because there were these dispensaries around the country, and I'm going to show you some data, that overprescribed like crazy. But then because we had a number of people who had become addicted through the use of these prescription drugs, that brought in a wave of heroin, which is a natural substance that is from growing the opium poppy. And then the third wave, which is mostly synthetic opioids like fentanyl that are illegally manufactured and in fact smuggled into this country. So if you look at the next slide, what we are looking at, that we are very well aware that the heroin wave, certainly that most of the people who were surveyed for addiction in a national survey of drug abuse, before they were using heroin, they were actually using prescription opiates, illustrating what I'm saying, how becoming addicted to those paved the way for the heroin. And if you look at the next slide, we also know, as you mentioned, that these newer drugs are far more potent. And this is actually an equivalent amount of a lethal dose. On the left side, heroin, the right, the fentanyl. Look how few grains of the fentanyl will kill you. And so, when this became spiked into the illegal drugs that were available on the street, many, many more people have become overdosed because of how easy it is to get the wrong dose of this drug. And for the next one. And so this is predominantly a problem of supply and demand. And I would say a major social determinant is simply, in one way or another, people becoming addicted. Either if that's because they were athletes who had injuries and were put on these substances, they could have had a lot of dental work at one point and they put on these substances. They weren't necessarily, as many believe, people who were suicidal or desperate or had mental illness. Some of them became addicted as an accident of misuse of prescription drugs, but of course many others not. And so it's a major social determinant that once people have become addicted, they have become prey, whether to heroin trafficking from Mexico or from the fentanyl. And for the next slide. And on the demand side, and this is from 2012, the peak year for opiate prescriptions in the United States. Many people think that this is a problem just of Appalachia or some other specific region in our country. That is not true. If you look at the darker areas, those are counties with unusually high rates of prescriptions for opiates in 2012, more than 112 prescriptions per 100 people. That is more than one prescription for every person in those counties. So what's going on there? That's where you may have had pill mills, people who are overprescribing, and that was occurring across the country. Those are the people, if you may, who became socially determined to be vulnerable to drug traffickers, vulnerable to overdose because they had become addicted. And so, you know, I think the dimensions of the problem are, they're national, they're impressive, and unfortunately, they've resulted in far too many deaths, far too many tragedies. I show the statistics, but behind each one of those is a tragedy for a family, it's a tragedy for that person, everybody in that person's system. And that's part of how our country has been so negatively impacted by this epidemic.
And I can relate to that as a pain physician, as an anesthesiologist. I mean, you know, when we're in the office, you know, there are lives being disrupted by this, and there's a lot of stigma that we have to deal with.
I'm going to talk about that maybe later, but yes, that is an enormous part of the issue.
Absolutely. But the data that you're presenting here, you know, we know that men are dying from opioid overdoses at nearly 3 times the rate of women in the United States. Opioid overdose deaths are increasing faster in minority groups than among non-minority. There is also a concern that there is a steep rise in young adults, ages 25 to 34, whose death certificates, interestingly enough, have some version of fentanyl. You know, knowing this and knowing this rise of a third wave with the data that we're seeing, you know, what can we do from a public health perspective in conjunction with public safety from your experience and your background?
So one thing I think it's really important to understand, in the third wave, we're actually looking at 2 epidemics. First, we're looking at that epidemic that's from this opiate prescription problem that I showed you, and all of the people who were newly addicted, many of whom were young people. But second, underlying that, all along, we've had a kind of a chronic simmering problem of heroin abuse in communities, mostly among older people, a lot of them men, a lot of them men from minority communities. And what happened is when fentanyl got introduced into the heroin on the street, all of those people, young, old, who were using, were likely to be killed via overdose because of the fentanyl being so potent. And so we are actually seeing a complex picture. In Washington, D.C., we did not see the same problem that many saw with, you know, suddenly a lot of people overdosing from their prescription pills, but now we're seeing a huge number of deaths from older people who have been addicted, some of them for 10, 20, 30 years stable, maybe in and out of methadone programs, but dying because of the fentanyl. But if you would go to, I think, slide number 8. So one thing that we were all trying to look at is, and this is advice that's come to clinicians from the National Academy of Medicine, but how we bring all caregivers together to be in a unified approach about taking care of people who have addiction. And I think that, you know, one of the important points that they raise is that everybody is a part of the same team, which has not been the case. The physicians have been over here, and law enforcement has been there, and social service has been somewhere else. That's also true that we haven't had we do now prescription drug monitoring programs. We also haven't had the use of the medication for opiate use disorder as we should have, not only in medical settings, but also in law enforcement settings, in prisons, in all institutions. It's safe to use that, and people who can become stabilized on medication, wherever they are then less at risk for overdose. So they've said there needs to be a large focus on community engagement. I can't agree more. You mentioned the word stigma, but this is a big part of the problem. And where can people go to receive treatment? There are a lot of funny things in the law about how treatment can be given, where it can be given, how it can be given, that make it difficult. Unnecessary barriers to treatment that need to be stripped away.
So talking about community engagement and availability of treatment resources, I want to turn to Mike. And increasing drug trafficking is fueling the fentanyl deaths in the United States. And for drug dealers, we know that illicit fentanyl is easy to get because it doesn't need to be grown. It doesn't need to be put in any place, really. It's actually easily supplied. It's a synthetic combination of chemicals, and it can be packaged very easily, according to the DEA.
Right.
From your perspective, what are the trends of fentanyl that you've seen locally here in Los Angeles, and what are you seeing in the nation?
Okay. Prior to this event, I reached out to our partner, and that's the Los Angeles Coroner's Office. I spoke to my contact there. She's the chief of the forensic section there. And pretty much she's saying that what the majority of the fentanyl-related deaths that she's seeing is coming from fentanyl being mixed with heroin, methamphetamine, and cocaine. Those are the majority of the deaths are coming from mixtures like that. Here in LA County, we had a little over 10 million people. We had over 568 opioid-related deaths. That's the unofficial number for 2018, as of April 2nd of this year. Okay, so 255 of those were fentanyl-related. Okay, 250, almost half. And again, the majority were from those mixtures that I just mentioned. The other part of it was counterfeit drugs, counterfeit pills. And the main ones that we're seeing, of course, are Oxy 30s and Xanax. And what's happening is the public, they think that they're ingesting cocaine, or they think that they're, getting an Oxy or a Xanax, and it's pure fentanyl. And it doesn't have to be pure to kill you. It can be, clearly a mixture, but it's fueling those numbers.
So as an anesthesiologist, in hospital settings across the United States, just to put this in perspective, fentanyl is used in hospital settings safely. I've used it over my career many, many times. Patients require fentanyl many times, and we use it safely. In the right hands, it can be a very powerful tool. And it can be legally used as a pain medication. But in recent years, as we're hearing, experts have suggested that fentanyl has been produced, shipped through our borders, brought in from foreign countries, and perhaps even mailed to users and to dealers in the United States, and then sold through the dark web. Mike, tell us, where is this illicit fentanyl coming from? Is there a pattern of money laundering that you have seen in your career that is fueling this third wave?
Yes. The majority of the fentanyl coming to the United States is coming from China. It's coming in the form of pills, powder, and precursor chemicals, being shipped to Canada, directly to the U.S., to Mexico, and to the Caribbean. In a lot of cases, the powder form that's coming over are also shipped with commercial pill presses, where they're making the pills here, and it's hard to tell the difference. I know I can't. I mean, I've seen the ones that my guys are seizing out there on the streets, and I can't tell the difference from a Xanax, from a counterfeit Xanax to a real one. The precursor chemicals are coming over to the U.S. and of course to Mexico, to clandestine labs, and it's being converted into fentanyl. A lot of the fentanyl, most of it, is actually coming from Mexico by transnational criminal organizations there in Mexico, cartels, and it's coming by tractor trailers, private vehicles through the ports of entries. It's also coming by airplane, subterranean tunnels, and of course by your mules or backpackers coming through our porous border along the southwest border. As far as money laundering, yes, these transnational criminal organizations, again, cartels, they're using trade-based money laundering, structuring, buying businesses purchasing businesses that generate a lot of cash car washes, restaurants, strip clubs, you name it. And we also see the use of casinos to launder the money and get it back over to Mexico and other countries. So that's what we're seeing here in LA. And a lot of my counterparts in other cities like Baltimore, West Virginia, Cleveland, Ohio, that's being hit with a lot of overdoses of fentanyl, they're seeing the same thing.
Yeah.
So there has been some suggestion that technology may have a role in this. And, that how is it that it is reaching our communities? If I enter a room of a group of people, there isn't usually anyone that says they haven't been touched by the opioid crisis. Every community in the United States has a story. So being that you're on the field, you're in the DEA, how is it getting to the suburbs of America? Is it technology? Does it have a role? Can you give us a particular story of what you've seen?
Well, yes. The main thing I've seen is the use of social media. A lot of the drug dealers that we're dealing with now, they know that we tap phones. They know that we track the phones, so they stay away. And a lot of their drug dealing is done over social media, the dark web, things like that. So we have to adjust. Now we do have some smart people that work for us that help us figure out exactly how to intercept the communication like that. And of course, this is just for the drug dealers. Those are the ones that we're going after, and that's what we see a lot. As far as how it's getting to the suburbs, the communities, yes, what we see is there are a lot of those cartels in Mexico. They ship it across the border. It goes to a lot of these domestic groups, organizations here. It goes to street gangs. Those street gangs see, it's profitable, and they make a lot of money from it. And they're putting it out there. They don't care. They do not care. About those citizens that are dying. They know what's going on. They see the news, but it's all about the profit. When I was prior to coming to LA, I've only been in LA for about a little over a year and a half. I was in our inspections branch at our headquarters, and I got a chance to. We did a lot of traveling, so I got a chance to visit locations like Charleston, West Virginia, Cleveland, Ohio, Baltimore, Maryland. The overdose death rate was just, I don't know. I've never seen anything like it. And of course, we're doing our best here in LA to keep LA and LA County and the surrounding areas from, becoming a Baltimore or Charleston. Because, like I said, right now we're at about 568 for 2018. Baltimore was well over 1,000. I think around 1,500. And they're a much smaller area than LA.
So I know you're doing some great work, and one of the things that the DEA is working on is the DEA 360 vision, and also the high-intensity drug trafficking areas, which you've worked on. Can you tell us a little bit more about that? What does that mean? And some of the work that we've just spoken about the collaborations with the DEA and the CDC. What are those interactions so that we can all understand? Okay.
The DEA 360 program has been around since 2014. Every year, DEA picks, with the use of CDC data, they pick 5 to 6 cities throughout the United States to implement the 360 strategy. This is again, it's been around since 2014. In October, Los Angeles became a 360 city. And what it is, this is DEA's answer to the opioid epidemic. It's a 3-pronged approach. You have enforcement, which is what we do every day. We go out, target those individuals and organizations that are putting the poison on our streets. Second is diversion control. This is our diversion investigators interacting with doctors and keep making them aware of the dangers of course, the controlled prescription drugs that they're prescribing and what it's doing, what to watch out for. But we're also, those diversion investigators are also targeting registrants, and of course that's manufacturers, doctors, researchers, you name it, that are operating outside of the law and putting those controlled prescription drugs on the street, allowing it to be diverted. And then last is outreach. So we've been doing a lot of outreach since October, since we became a 360 city. We've been reaching out, going to different schools, talking to the students. Here, actually here this Thursday, we have an opioid awareness youth summit at the Dolby Theater where they hold the Oscars. We have about 2,000 high school students from age 9 to 12 coming to the Dolby. We have several great speakers to help us get that message out about the dangers of opioids, including Dr. Drew Pinsky and Brian Novak, Derek Fisher, and a few others. That's going to help us get the message out. So that's pretty much what we're doing. As far as HIDA, I work at LA HIDA. LA HIDA it's the high intensity drug trafficking area. This is a program that falls under the Office of National Drug Control Policy, which falls under the president. And it's a program where it brings all of your federal, state, and local law enforcement agencies together in one building, and we utilize each other's resources to go after the drug traffickers and organizations that are putting this poison on the streets. Here in LA, at the LA HIDA, we have LAPD, LA Sheriff, FBI, IRS, all of the federal agencies there. And we've been around since 1994. LA was one of the first ones. LA, Miami, Houston, New York.
So given the work you're doing in Los Angeles and the numbers that you're seeing in California, right, my concern is California has actually been one of the states that has had the lowest number per capita of opioid overdoses and death rates in the nation. But given this third wave of fentanyl, the concern is that it may actually go up. And we've heard about some of the community public health efforts to date to curb the opioid overdose epidemic, the prescription drug monitoring programs, the reduction of prescription opioids, the DEA programs to take back the pills. But the question is, will that stem it in California and the nation now? And from a DEA perspective, from the public safety perspective, what will happen in California? Can we stem it here from a public safety perspective? And what can we do for the nation?
Well, we're definitely doing our best. We're doing all.
I know you are.
We're doing all of those things that you just said, including working with treatment, prevention, recovery organizations. Just 2 Saturdays ago, we actually have brought in, under this 360 program, we brought in all treatment, recovery, prevention personnel from all over LA County to one of the small suburbs here, and we got together and we just came up with strategies on how to combat this opioid epidemic. So as far as what additional things that LA is doing, we recently came up with what's called an opioid response team. Now, like I said, when I was in inspections, traveling from city to city and getting a chance to see what the other DEA officers were doing, I visited Cleveland, Baltimore, and Charleston, West Virginia. Charleston, West Virginia was probably the worst I've seen, because I used to live in St. Louis with DEA, and I used to travel back and forth to Quantico, Virginia, where our training academy is located. And I used to stop in Charleston, West Virginia, quite a bit. And it was a nice city, a lot of people. It's just a thriving city from what I saw 15, 20 years ago. When I went about 2 years ago, it was the downtown. I stayed at a Marriott downtown. The streets were dead. I spoke to during the inspection. I spoke to the U.S. attorney there in Charleston, and she said that they're just being hit very hard with the opioid epidemic, with prescription pills and fentanyl, and it's so bad that the local businesses they can't find qualified employees because they're all testing positive for opioids. The city was very bad. Same thing with Baltimore. Same thing with Cleveland. So I took when I arrived here in L.A. I took this to my supervisor, and that was to come up with an opioid response team. Because what I found was that opioid-related deaths were not being investigated once they are deemed accidental. Okay, so we brought in all the right people, of course, including the coroner's office. And when I brought it to the coroner's office, she said, "Hey, look, I've been waiting for law enforcement to get involved because this is getting out of hand." And sure enough, we created an opioid response team. We go out, and what we do is just work that investigation to try to find out who delivered the fatal dose of opioids. And we've been very successful doing it. The U.S. Attorney's Office is on board, and they have a charge. It's called distribution of controlled substance resulting in death. It's called the death enhancement. It's a 20-year minimum mandatory sentence if you get convicted of it, and definitely a big deterrent. And we've been doing very good with it.
Thank you for everything you do. Thank you very much. So we've heard the public health. Thank you. We've heard the public health perspective, the public safety perspective, and now I want to go into the doctor's office and what happens with the clinician's perspective. And I want to hear from you, Adrian. And myself being a pain doctor, I know I've struggled quite a bit with the doctor-patient relationship in treating pain, but there has been a shift in the doctor-patient relationship. Many people that have misused prescription opioids now it has been suggested that they are shifting to illicit opioids, such as heroin and fentanyl. And an increasing number of people believe that this is an issue in our society, that they are not getting their prescription opioids, and this is a rising concern in society. So the patient who has surgery, who has trauma, that develops a substance use disorder, this might be a familiar story to you. How do we move the needle? How do we change this public health emergency to a public health solution that is focused on education, on the safe use of medications? I know that's a tall order.
Yeah, that's a lot of questions.
But I want to hear your thoughts.
Well, first of all, I have to say, I think I live vicariously through Mike and every TV show I watch, so I just want to say that for the record. Sorry, that's not appropriate probably, but I was just getting goosebumps listening to him going, but I'm like, wow, this is so cool, and look at what I do. As a scientist, this is not that exciting, but you know, when I watch the slides, and I have them in front of me here, and I listen to our speakers, whatever, I keep looking at the slides, and I look at the slides, and you know what I keep picking up is people are hurting. Americans are hurting every freaking day. And you know, I feel sorry for Mike because he's getting at the end result, but if we cannot listen to these conversations and not look at a human being, an American at this, which that's what we're talking about, what I'm hearing is people are hurting. They're hurting really bad, and they are looking for answers, and they're looking for it at the bottom of a tablet. They're looking at the end of a crack pipe, if that's the right term, I don't know. But there's something wrong here. People are hurting really bad, and we're giving them really, really bad answers. You know, the bad news right now is that, for me at least with the research we're doing right now, is people are viewing pain very wrong. You know, every day, hundreds of thousands of healthcare providers wake up every day, and we walk into the office thinking, we're going to kill all pain today because pain is the enemy. Pain is a normal human experience. Without it, we'd be dead. If you break your leg today, pain is a good thing. It teaches you do not run the LA Marathon tomorrow, go get some help. And somehow we have changed society to make them believe that pain is a bad thing, pain is abnormal, and let's kill it. And let's kill it with drugs. And we have to change the pathways of how we treat pain. And so, I'm sorry to mention it, but I mean, we mentioned high school kids, what a great thing to do. But I would start even before that. We're teaching little kids, when you heard kids Tylenol, when you heard kids ibuprofen, FDA just cleared hydrocodone for kids 8 and above. Via Pavlov, we are now teaching kids pain equals drug, pain equals drug. And until we fix fundamental pain literacy, how we view pain as a society, I don't see how we're going to change it, not even close.
So, you are very active with patients and you do a lot of great work. And, one of the questions that I often hear is that in clinical environments is that we should have balanced pain management, more comprehensive care. But that sometimes can be a challenge, and it can be very difficult to have that kind of comprehensive care in the clinical environments. Do you believe, looking in the past, that if we had better balanced pain management, that we could have stemmed this third wave that we're all talking about here today? And looking forward, what are the challenges? What are the challenges that we're facing? I know that patients are asking more questions. They're more aware. They have access to a lot of knowledge. How does that change the environment that we live in?
So I almost want to go back. And first of all, I do believe we could have done better. And we were doing better. If you look at way back in the 70s, 80s, people like Lozier did amazing multidisciplinary care. We had answers, but somehow it got bypassed by the pharmaceutical pathways. I'm kind of getting tired. We keep talking about the word multidisciplinary, interdisciplinary. It's kind of like a nasty word anymore. It sounds really cool, but we're not doing it. And I know why, because there's a financial implication. In the medical community right now, multidisciplinary means it's money, it's cost. It has been proven. There are enough research right now to prove that multidisciplinary, interdisciplinary care, and there's the slides in front of me, team-based approach. It cannot be, cannot be physician first, and if it fails, then go do something else. It cannot be that anymore. So I do believe that the research strongly points in that direction, because pain, I listened today to an amazing presentation, but I mean, pain is such a complex individual experience that one approach cannot be the answer. We have to have psychological care, and I hope everybody at Milken will agree with me that we have a fundamental problem with mental health in this country to start with, and pain ties into that so powerfully. So I missed your question, by the way, I know that, but you said the right thing. Politicians are not going to change this. If they wanted to, they would have. The pharmaceutical industry will definitely not fix this. I believe in our patients, because they are showing up and asking questions, what else can I do, and not do the drug? Will the yoga help? Will mindfulness help me? Will breathing help me? Will whatever help me? So, I'm sorry, but I think we need to, maybe I'm too optimistic, and I'm looking at Mike because I know he sees the really, really bad stuff, but I do see patients showing up asking good questions, the right questions, and sorry for the language, but by God, I think our patients are going to show us the right way, because the right people are not showing us the right way right now.
So patient engagement, we've heard a lot about that at this conference, and certainly there are a lot more questions. But what are the options? What can we do for patients who are suffering with pain? What are the innovative treatments? And how does education play a role in this, in society in general, not just for pain, but also for substance use disorders, for individuals who are currently, in a state of addiction, who are stigmatized and require treatment right now?
Yes, I think I will answer it. One is kind of pre-addiction, if you will. Just as an example, there's some incredible data right now to show us that our clinical pathways, if you hurt your back pain is the number one condition short of the common cold, that takes you to the emergency room. Dr. Smook and his team at Stanford showed us the pathway to opioid addiction starts in the emergency rooms. It's well documented, well covered, we know that. There is studies now to show us that when you hurt your back, but instead of going the medical route, and this is not a knock on any of my physician colleagues, you go the physical therapy route, the chiropractic route, you have a 70 to 90% less exposure to opioids as your first treatment. And again, I understand there's a time and a place for these, but our clinical pathways have to change. If the first thing you encounter is the drug or the person that gives you the drug, that's the only option. So it's that side. And Anita, the other thing that I also want to mention is, I mean, we started, we now have it in 9 states. We are teaching middle school kids, 5th grade, 6th grade, 7th, and 8th grade about pain, how pain works. And I'm very happy to report that 5th grade kids can now sit in a classroom and go, I got it, I know how pain works. And by the way, pain does not mean drug. And so we have to change society, no doubt about it. If we switch to the other side, what about the patients, you know, from Mike's side of whatever? It keeps bringing me back to a study that came out in 1975, mind-blowing research when the Vietnam War ended. You know, there was a significant concern about soldiers coming back from Vietnam being addicted to heroin, and oh my goodness, we're gonna have a major problem. And the study showed us as soon as they engage into society, back to normal life, family life, caring people, 90% stop using heroin, cold turkey, done. And so when I bring this back to, are we creating the environments to help the addict? It pains me when I hear a person in Virginia, West Virginia, cannot get a job because they're positive, but they really need a job right now. We need to change our system where addicts can be helped, embraced, yeah.
Mm-hmm. So tying that back to this third wave and public health, I want to come back to you, Lynn. Because when we started this discussion, I mentioned the word stigma. And I think there is something here to talk about. And we've talked a little bit about patient engagement. How can we move the needle on this, right? We've talked about there's this, you know, cultural boldness in patients. They're asking more questions. But at the same time, there is this despair. There is this hopelessness. There is this loss of productivity in the workplace. And there yet is this rise that we have heard so eloquently from Mike in deaths due to fentanyl, this third wave. I want to hear from you specifically, what can we do to get access to treatment to those individuals who feel stigmatized?
Thank you for that. I'm going to start actually with slide number 7, because I think that, you know, we've heard about West Virginia and certain parts of the country that have been labeled and rightfully as having high levels of death from opiates. The last year where we have national data, unlike LA County where we have an insider on the stage, is 2017. But those dark red areas are all the places in the country with extremely high death rates. But I would say all of these rates are high compared to the rates 20 years ago. And it's to say that it isn't any one state or county or city that is suffering from this. And this is not about people in any one place. I believe this is probably where the fentanyl has successfully been dealt in to a system where many people already are addicted, right? And so they're dying of overdose. If you go to slide number 10, so one thing that makes me hopeful is the fact that there is the ability to recognize that all of these people who are at risk for overdose are suffering from actually a treatable chronic brain disease. They have a disease. They aren't addicts. They have addiction. I think that's a very important distinction. They are people first. And that there are FDA-approved medications that are effective and work. And that if we can keep people on that medication, they have improved outcomes. We know that. We can save their lives through that. And that yet there are many excuses for which that we don't use it. We say, well, they have to have the behavioral interventions. And we don't have enough psychologists and psychiatric treatment across the country for all of them. And we say that when we can't apply them in criminal justice settings or schools or other settings, it can only be applied, you know, within a certain setting. There are barriers, not only the stigma, but also the education of professionals, but also the fact that there are regulations that restrict the ability of providers to prescribe these medications that are not supported by evidence, according to the National Academy of Sciences. There is no evidence behind those restrictions. We make those restrictions for no other medications for any other diseases. If you have a heart disease, you aren't restricted to prescribe your patient's medications. But yet, if you have a treatable chronic brain disease called opiate use disorder, we can restrict your ability to use those medicines. And we, of course, have fragmented care and problems with payments. But the good news is, though, that these medications can be used by many clinicians in a variety of settings. The next slide, if you don't mind, number 11. The other thing that I think is very, very good news, one of the huge problems has been the steep rise in cost of naloxone, which is the remedy for opiate overdose, which somehow, as the epidemic occurred, the price went up about 200-fold, right? And FDA, and I have to thank Scott Gottlieb, I'm very sad about his departure from the FDA. This is one of the last things that he did on April 19th. They approved a generic nasal spray. And that is wonderful for two reasons: less expensive, but also anyone can deliver it. You don't even have to use an injection. And even though it's very frustrating to save people who then go on to overdose again, that's part of the disease. And that's part of what we all need to understand, that relapses, many relapses, is part of the natural history of recovery from this disease. And it's great that we now have access, or will have access, to a less expensive remedy.
Thank you, thank you. And I agree. I mean, this is such an important step to address public health, and also, I would assume, for public safety, Mike. And with that, we have heard a lot about how we can drive prosperity together for public safety and public health today, for the opioid crisis, for this public health emergency. And we have learned really how to take a more personalized approach, how to have a safer approach, and really how to have a more effective approach. But I do want to have one last question with all of you. And one that we all can get engaged in. And I really want to ask each one of you, and I'll start with Mike, what is the one thing that each one of us can do here in our own communities to address the opioid crisis, to drive a shared prosperous community that we each live in?
Well, I would say, just it's with your kids, get the word out early, and that's what we're trying to do with this summit. We're doing a lot of outreach activities. So I think it needs to start at home. Also, let the kids know, hey, look, this is what's going on out there, what to look out for. DEA, www.dea.gov has all the information that you need to know for all drugs, for all illicit drugs out there on the market, and the prescription drugs, and that's pretty much what I would say. Just start with the kids, start young.
Thank you. Adrian?
Yeah, it's a loaded question. I mean, I agree with Mike. Start them young as we can. I don't know if it's the right answer, but something that keeps striking me is it's kind of the classic thing we always say is, you hate the behavior, but you love the patient kind of thing, right? And so I think if I have to ask people leaving the Milken Institute, leaving the conference, is if there is an addict in your life, if there are addicts in your community, is not to reject them, but to love them and care for them. The research currently shows that if we do the intervention part of, if you don't shape up, we don't want anything to do with you, it is probably the worst thing you can do because you alienate them socially. And it's just easy to say, obviously sitting on a stage in front of a lot of people, but if it's one thing, I'm not from LA, I'm starstruck, I walk around, I see the big city, but we also see the homeless people, we see people, and as we walk tonight the streets, we walk outside and you see a homeless person, when last have we asked somebody, how you doing, how can I help you? This conference is about help, making this world a better place, but let's start with people that really need some help, and that our addicts need help.
Yeah, kindness goes a long way. Lynn.
I really think that Adrian put his finger right on something that's very important, and that is that in one way or another, we're all a part of stigmatizing people, not only who have addictive disorders, but also other mental illnesses, and that we need to break through that, or we cannot rationally approach being able to take care of these as brain diseases. And I think I also agree with Michael about starting at home. I don't want to embarrass you all by asking you to raise hands, but I would wager that many of you have a little stash of some kind of an opiate in your medicine cabinet, just in case that somebody has an injury or there's pain, you save them. I used to do that. And I think that the point that Adrian made, that is not the first thing that we do to treat pain, that if we do that, what we're teaching our children, but also it's there for them to access. It becomes a temptation for friends and relatives who are addicts. And if you do have that, to dispose of that properly and to think about whether the next time you get one of those prescriptions, do you really want to fill it? Do you really need it? A lesson for me, my daughter had her wisdom teeth out. She was only 17, came back with a prescription for 30 OxyContins. And I had to think, why? What for? And it said, take one every X hours. It didn't even clearly say for pain. And she would have done it.
Well, this is part discussion that we need to educate, and I think that was a little bit about changing, how we educate about prescribing pain medications in this country and how we treat pain, and I think that will really be part of the solution.
Thank you so much.
Thank you all very much. That concludes our session.
Thank you for attending this session. Please join us for a cocktail reception in the pavilion, which will begin in a few moments.